think the first thing to remember is that a bilateral pelvic lymph node dissection is a critical component of a radical cystectomy done for intent to cure. It does two things. It identifies patients with pathologic node metastasis, and it is an important component of what we call local regional control. In other words, before that became incorporated into cystectomy, the local pelvic recurrence rates were 30 to 40%, and presumably that's due to occult metastatic disease in the lymph nodes. And when this bilateral node dissection became a standard of care quite a long time ago, that local pelvic recurrence rate dropped down to 10 to 15% because you're removing, occult metastatic disease. All right, so standard. Let's just sort of get some definitions down. The primary lymph node drainage for the bladder is obturator lymph nodes, external iliac, and internal iliac. And that's what we call a standard node dissection, complete removal of all lymph nodes in the obturator fossa. And then the extended template goes up to at least the aortic bifurcation and potentially up to the inferior mesenteric artery, and includes bilateral common iliac, presacral, and lymph nodes lateral to the common iliac vessels. So a number of us were taught, and we were kind of disciples of Don Skinner, who popularized, who wrote extensively about the importance of this, and but yet it had never been tested formally in a clinical trial as to whether removing additional lymph nodes, removing potentially additional areas of lymph node metastasis would improve outcomes measured by disease-free survival or overall survival. So that's the hypothesis that we tested in the clinical trial. All the patients were being operated on with the intent to cure. Everybody got a bilateral standard node dissection, and the randomization was to an additional extended lymph node dissection. And what we found was that there was no difference in disease-free survival or overall survival with 6+ years of follow-up. We did find more lymph nodes. We did find more lymph node metastasis in the extended dissection, but it didn't accrue to any kind of benefit. Now, part of that was in part due to early events in the first 90 days and a lower event rate overall. But it essentially ruled out a 10 to 12% improvement in DFS and OS. It doesn't rule out, smaller margins of benefit, but you'd have to do a trial of 1,500, 2,000 patients, and that's just not going to happen. So you take the results of this trial, the results of a similar design trial that was completed and published from the German group, and those two trials, and that was also a negative trial. And those two trials together essentially establish that a bilateral standard node dissection as the standard of care for curable muscle invasive bladder cancer patients undergoing a cystectomy. No, I would say that we're done with as far as it relates to the target population, which was predominant urothelial cancer, T2 through T4A, N0 to N2, so clinical nodes confined to the true pelvis, and no evidence of disease in the extended template at the time of the initial exploration. So, there's a lot of patients that it doesn't apply to. Patients with clinical N3 or clinical M1 nodes in the retroperitoneum. It certainly doesn't apply to patients who start out with a T4B tumor, which is unresectable, that becomes resectable with chemotherapy, for instance. It doesn't apply to patients with predominant, variant histology, such as squamous or adeno, for example. But it does apply to the majority of patients that we're operating on with the intent to cure.